All right. Hello and welcome, everyone. This is Caleb from TASC at the National Rural Health Resource Center. Today is Wednesday, April 15th. This is the first introduction and data utilization session for the Population Health Learning Collaborative for fiscal year 19. Today we have Tracy Morton, Director of Population Health, to talk about and kind of give a little introduction to population health and data utilization. We had our first homework assignment that hopefully everyone was able to access Teams, Microsoft Teams. We're utilizing that as our digital forum and discussion forum. Homework assignments will be placed in there, as well as questions and answers. So thank you for everyone who's been able to access Teams and made some comments in there. We do appreciate that. We want to make sure the Learning Collaborative as a whole is as interactive and beneficial for you guys as possible. So in keeping with that, we've transitioned to using Microsoft Teams for discussion forum and homework assignments, as I said. If you've not had a chance or have had any issues getting logged into Teams, please let me or Andy know, and we'll get you logged in and the technical support we need to do that. We have a couple polling questions both today and then as we go with the webinars, so we can make sure the education that we're providing is as beneficial and helpful to you as we can. You hopefully can see myself and Tracy there on the right in your Adobe room, and that's really just to engage, to increase engagement. So I welcome, or I encourage you guys to utilize your webcams if you have them and say hi. You can see Marbles there in the background, my co-pilot, and I know Tracy's at home with her family as well. So thank you guys for joining us. Please take a second to complete the polling questions. We will have a short presentation from Tracy about population health, data utilization, and then the last half of the scheduled time is really open for discussion. We want to hear from you guys how you found the homework assignment, what you thought of it, how it was beneficial, and what you think you might be able to do utilizing that data as you move forward with activities related to your FLEX program. And that will be the structure as we go. We will have, as we saw in the previous slide, topics on behavioral and mental health integration, community engagement, finances, and telehealth services, a bunch of different topics related to population health. And thank you, Natalie, for joining us on the webcam, as well as Stephanie. Thanks, guys. Welcome. All right. Andy, what notices am I forgetting? Please do dial into the conference line. It's in the chat box there. *2 will unmute your line, and you will want to mute your audio in the Adobe room, otherwise it creates a feedback loop. All right, if we don't have any questions, it looks like Maria's typing into the chat box. Once we get all our questions answered, our polling questions, and then address any questions in the chat box, I will let Tracy get started.
All right, Caleb, I think I'll go ahead and get started here. It looks like Maria's having some phone issues, so I'm sure Andy can reach out and help her with that as we move along. So, hi everybody, welcome. Thanks so much for joining us today. It's it's such a different environment now that we're all working from our own houses too. So nice to see you all where we can see each other. So thanks for taking the chance to join today. And my role today is just to kind of provide a little bit of a background and overlay of getting us on the same page about what we're talking about when we're talking about population health, and then we'll explore a little bit of the data too. So really today we'll talk about the purpose of it, incentives for working within population health for hospitals, clinics, and their communities, and then a little bit about the numbers that can help make it happen. So I think you know who our organization is. I won't spend time talking about that, but there's a slide in here that explains who we are. And again, TASC, the Technical Assistance and Services Center, is funded just like you are through the Federal Office of Rural Health Policy, and we are just one of the many programs and services that happen at the National Rural Health Resource Center. So today we'll talk again about what is population health, who are the players within it, kind of briefly overview of that stuff because I think you guys all know those things. What are some of the incentives and kind of dive into kind of an altruistic maybe approach to some of those incentives, and then sometimes talking about the data that can be used to inform decisions and progress both for us as entities at state levels, et cetera, and then also for the facilities too. And then we'll spend some time talking in the latter portion of our time here today. So this is a definition that I really, really like about health. And I just find it that it's very all-encompassing. And it says health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And you know, if we think pre-pandemic time, really within the last few decades within our hospitals and our clinics and our health centers, we've been focusing on disease and infirmity. We've been focusing on fixing what comes through the door, sending people back off again, and then hoping they don't come back, but oftentimes they do as well with something else. And we're not treating people, generally speaking, within this whole aspect of care that thinks about the complete physical wellness, the complete mental wellness, and the complete social wellness of that individual to create a full picture of health. And what I find most profound about this definition, and many of you have probably heard me talk about this before, is that this is from the World Health Organization from 1946. And it was put into force in 1948, so 50-some years ago, and we're still trying to wrap our heads around this and do it the right way, if you will. And I think over the last 15 years or so now, we've seen this shift within our country, within our healthcare systems, to move into really focusing on what is health and how can we create health, but it's taken a really long time to get there, and it'll take longer to still kind of get there too. So to kind of keep us all on the same page here too, this is a definition that we often use within our organization about what is population health. It's from the American Hospital Association, and it talks about population health as really a strategic platform that can be used to improve the health outcomes of a defined group of people, concentrating on...
The organizer has disconnected, and this conference will continue for 60 minutes.
The first stage, and hopefully our line keeps going here, the first stage is about the distribution of specific health statuses and outcomes within a population. So what does it look like? What does it look like within a group of people that we're talking about? And could be, what does it look like? Could be many different things, diabetes, whatever. The second stage is looking at the factors then that can be used to cause those certain outcomes to be present. So what are the things that influence that? And then the third stage in this strategic platform definition of population health says, what are the things that we can intervene with to modify to create health, to create more health in the population? So that's the definition that we really like to use about population health, that it's a really strategic platform to talk about what's going on within a population, what the outcomes are, and then how we can influence that. Moreover, I think it's really important when we're talking about population health to kind of define maybe the small n and the big N, if you're following me with that kind of statistical sort of jargon there. But thinking about the small n as being that targeted population. So it's about improving the health of a finite, really defined specific group of people. So for example, it could be individuals that are 65 years and older that are on Medicare and Medicaid, so dual recipients, and are pre-diabetic. So then it's looking at a group of people that are 65 years of age or older, they have a certain type of insurance, and they have a certain type of health condition. So it's a very targeted population. The other type of frame for population health is that big N, and that's looking at total community health. So it could be that describing the pre-diabetic population for the full market share of generic rural community hospital. What is their pre-diabetic potential capture? So that's that total community health, the health outcomes of an entire group of people. So that's really important when you're talking with people and coming into kind of specific examples about moving on population health within that strategic platform to really understand whether or not the person you're having a conversation with is talking about a targeted population or total community health. And that's important because it changes our minds about how we would intervene and what we would do about it, and also about resource allocation with that too. And then population health management is another term that's used kind of in tandem with population health. It's kind of the verb tense of it. It's very clinically motivated, but it's talking about the process of improving clinical health outcomes in a defined group of individuals as they move through care coordination and patient engagement. And it's really relying very heavily on data to kind of move that process along. So it is kind of the verb that goes with population health. So now that we kind of laid out the groundwork about what that definition could be, this is a slide you've likely seen from our organization before too, and it's saying that population health has lots of different partners. So I think the obvious ones are, hospitals, clinics, maybe mental health providers, and public health too, or maybe some classic ones that we think of. But there's other people, other partners that influence population health, like schools or long-term care or social services. Faith-based organizations can have a tremendous influence on the health of a population. Any kind of group where people congregate with shared values and beliefs, or shared likes too, like businesses and purchases that you would make from a business can influence the health of the population. There's lots of different partners out there that influence population health. And along with that, there's actually a lot of going on with different, what I'll kind of term as players now that are influencing population health. And what those look like are big corporations as well as other entities that you've likely heard of before. And these are some on the screen here that they've been in the kind of the health realm for a while, and then there's some that are kind of moving newly into it. For example, Amazon Web Services is like maybe a classic example that you would think of as a healthcare or a health-related entity, but they certainly are. And not only are they partnering with our kind of classic normal partners within healthcare, but they're strongly influencing health, and they're driving innovation, they're driving processes, they're reworking systems, and they're adding to or sometimes skipping over existing partnerships that were around before. So, and then all of these organizations, and this is just a smattering of them, are really involved with lots of big data. So they have lots of numbers, lots of access to information that they're drawing upon for decision making and for also moving towards risk as well. So there's lots of different players now that are entering into the sphere of partnerships when we think about population health. So to shift a little bit into incentives, and I talked before as I was opening that I feel like some of this is a little altruistic, but I think it also gets into kind of some of the values that we have around healthcare within our country, and what some of the motivators are too. So this is an example here from the Institute for Healthcare Improvement, and I'm reading some notes here as well. This is from IHI, and it's looking at 6 foundational concepts about the pathways to population health. And if we look at the far left side of your screen, your far left, there we go, it starts with kind of what are the factors that create health. And the first and foremost is that health and well-being of an individual develop over a lifetime. They're based on decisions that we make, genetic predisposition, and then a whole bunch of other factors as well. But that kind of is what starts as kind of the foundational concept for that. And then as we move to the right and looks at how our health is influenced by something called social determinants of health, I'm sure most of you have heard that term before. It's about where we live, work, play, age, and how those set of forces that are often outside of our control can influence those health outcomes. And as we shift a little bit more towards the center into the third foundation there, we're looking at the things that how place is such an influencer or environment that we live within is an influencer within our health. And so an incentive there is to adjust our place or environment as we can. The fourth foundational concept is where really the healthcare system comes into play and how healthcare can get engaged with the concepts or the foundations and the strategies to influence the health of a population. And so this is by health systems really acknowledging and then addressing key demographic shifts We've seen this over the last few decades within our country with shifting prevalence of chronic diseases and just how they are tremendously bubbling up and how we manage those. We're also seeing continued efforts as well as some amplified efforts to address health disparities within demographics, and also, of course, very relevant to our rural areas, but relevant to our entire country, is addressing the aging population for the next few decades as well. The fifth foundational concept then is looking at how healthcare systems can embrace innovation and finances to maximize existing assets. So the things that they already have, the things that are not new, but how can they maximize and operationalize things that they already have financially to be able to innovate? And then lastly, the sixth foundational concept, way over to the right side of your screen, is looking at partnerships and using partnerships as really the glue that kind of holds this all together, recognizing that nobody can achieve health of a population or themselves really alone. So these are some of the foundational incentives that were identified through the Institute for Healthcare Improvement. And so it's about, getting back to our basic health concepts, improving social determinants of health, evaluating our place, kind of acknowledging our shifting demographics, looking within our healthcare systems about how we can maximize the financial strategies that we currently have to seek innovation within those. And then sixth is really focusing on strong partnerships and collaboration to get the work done. So there's additional incentives that kind of play out within all of this too, and that is looking at some concepts that kind of also tie into an IHI related component of the triple aim, which was then, of course, adopted by CMS as well. And that's first and foremost that we need to move out of this unsustainable healthcare system that our country is currently within. There's no reason in our country that we should have the most costly healthcare within the world with some of the poorest health outcomes. But as we move through this system, we're all experiencing this, is that we're moving through this shifting healthcare environment as it's kind of developing unevenly across the country as well too. So we're kind of stepping on these stones as they're shifting underneath us and finding some that are relatively stable and we can feel firm within what's happening there and learn from it, and some that slip right out from underneath us. And I think what to hypothesize a little bit, and I imagine you're all thinking the same thing, is there's a tremendous amount of innovation that's happening right now with dealing with the pandemic, and that will continue, I think, to push innovation into the future so that we actually won't be sliding back into a healthcare model like we saw even a month ago in our country. Another incentive for shifting into population health is just to drive down the per capita cost. We know it's not sustainable. It's not sustainable for the healthcare systems. It's not sustainable for insurers or the health insurance payers. It's not sustainable for employers to continue to support premiums for employees, and it's not sustainable for individuals to support the costs that go along with insurance. So our marketplaces created these share saving models, some of which have some amounts of risk to them, but it's really focusing on better cost controlling within any of that to maximize what it is that we have to do. So kind of to get back to one of the statements I said before about having such tremendously costly health insurance or health care in our country with poor quality outcomes, of course an incentive is then to improve the experience and improve the outcomes of care, focusing on quality, satisfaction, but that couples along with things that have been challenging for us to adopt within our country, like electronic health records. How do we get information in them? How do we get our provider base to actually use them? And how do we actually get that information out of there, or let alone share it with another entity that could be just down the road with us through a health information exchange? So those are some tremendous hurdles that we're still working on crossing. And lastly, I think the biggest incentive is one that I think that most of us can get behind, is that we want to have healthier communities. And so what that means for our healthcare organizations is that they need to identify their relevance within those communities. They need to be able to rethink care management as not just the care that happens within their four walls or within their follow-up calls, but actually how they can create community care coordination and community care management to best support people, leveraging the assets that exist from partnerships. And they need to, of course, become the provider of choice within their community for the services that they provide, and the ones that they provide well, not the ones that they could provide is just as another opportunity. And being that provider of choice just, creates a stronger community, creates a stronger economic situation within the community where people aren't having to travel far away to go seek services. They can use their dollars within town and can maximize their health there and are proud of their community. So to realize population health and kind of tie this all together, some of the aspects that I think our organizations need to focus on is that we need to collaborate with partners to be successful. We need to rethink the way that we view partnerships and not compete with those down the road. And I think we're seeing a lot of that happen right now in our situations too, with sharing information and being vulnerable in a time when we really truly do need help. So we need to leverage partners' strengths and their assets and say, you know what, we both are doing the same service. You do it a little bit better than me. How about you do it? We'll refer back and forth to each other. That's what a partnership can look like to achieve population health. I think we need to keep asking why not. Why can't we do something in a certain way? Just because it's always been done this way, why can't we do it differently? And we need to innovate and, of course, address those social determinants of health. I think one of the classic examples that we see within rural areas is that, transportation is a barrier for people to get to a community, or to get to the clinic or whatever. But maybe there isn't a public transportation and there isn't even a ride service in town. And so sometimes they just say, well, that's just what it is. Why not address that? Why not think creatively to provide an opportunity for somebody to get their health care, but also an opportunity for somebody for employment as well? And then I think the ultimate thing is to strategize and have a vision of where you want to be going as an organization. They need to have clearly defined strategies. Those strategies need to not just be a bunch of fancy words, but they also need to focus on actionable items. And those items need to seek measurable outcomes that can be monitored over time. So that measurable outcomes part is what moves us now into a little bit of the data discussion. So two different types of data that can be used to make informed decisions. Those that are clinical decisions, focusing on clinical data. And so some ideas, that data is used, of course, for real-time kind of care coordination. It's also used for future strategy as well. And that clinical data comes from a lot of different sources. So the electronic medical records, partner records for care coordination, that health information exchange, or HIE, market share analysis, out-migration analysis, cost recording, patient risk analysis, hotspotting based on demographics or conditions or language or whatever it may be. But I think that clinical data sources and the clinical decisions are also made by data that's not quality or clinical in origin, but actually some is based on financial data, and I think it ties a little bit in with the charge master. So if you follow me with this here a little bit, if your charge master is readily updated and regularly updated, it allows you to ensure that you're getting paid right. And if you as an organization, as a healthcare provider, are getting paid right, you have theoretically, or could have theoretically, money to be able to support that patient care navigator that you want or that care coordination manager that you need. If your charge master is out of date and you're not maintaining accurate cost controlling, then you are throwing money essentially out the door where you could optimize that to support population health strategies. So I think a lot of those clinical decisions and data decisions rely on clinical care. They rely on patient demographics and information like that, but that all ties together with finances as well. Community decisions, of course, can be used to focus on immediate issues that are arising within the community and, of course, inform future strategy, too. And all of that clinical and community decision-making really should tie into the organizational strategy as well. The community health needs assessment shouldn't be a standalone document that's outside organizational strategy, nor should clinical data nor financial data. It all should be informed into that organizational strategy as well. And I think that healthcare organizations need to be thinking about, and I think they often do, what is the vision for the health of the community? But I think they should play a little bit of a scenario out of what if the hospital wasn't here? Not that the hospital closes, but just what would this community look like if the hospital wasn't here? What would the vision for health look like in this community? I'm sure that the population there would still want to have health. They would want to be healthy. So I would challenge people to think about how can the hospital support the community's vision of health versus the other way around of the hospital dictating what health of the community looks like and then trying to respond to that. So to get into a little bit of what the data might look like that we could have access to, I wanted to provide a list of different sources here for you guys, and this ties in with your homework example too. So it may be possible that at your organizational level, you can have access to clinical roll-up data for your state. And if you have access to it, that's awesome. That's so great. You could use that and do tremendous things with developing program activities and things like that. If you don't have access to it, that's okay too. There's a lot of different other data sources that are out there that can help inform your decisions too. So some that are listed here on the screen, and I'll kind of run through what they are, but they're hyperlinked for your use as well. So hospitals, all nonprofit hospitals in the country need to complete a community health needs assessment on a 3-year cycle. If you want to talk more in depth about what that is and what that means, let me know. I'm happy to talk that through with you. But those hospitals that need to complete one also need to make it publicly available. So most of them opt to post it on their website. If they don't post it on their website, you can, as Joe Public, request that from them. They need to provide it in a paper format as well. But most of them have it on their website, or you should be able to find it. And also a lot of nonprofit facilities are actually completing it because, again, it informs organizational strategy. Those are a gold mine of information. Some of them are conducted, or they all are conducted in various different ways, so they can be a gold mine of information about what's going on within the communities in your state. Your state also likely has some different data repositories, so your state health department is likely collecting data in various different formats and may release things publicly, or you can do a query and ask for data that they're able to release in a non-identifiable way. Also, state hospital associations and things like that often have different data repositories too that you may be able to have access to. CDC Wonder is a fantastic queryable data set that exists about a variety of different health conditions. So I encourage you to kind of tinker with it. It can be a little clunky at first to kind of navigate through. I'm happy to talk it through with you, or trial and error could hopefully help with finding the data that you're looking for too, but it's just a great data set there. County Health Rankings and Roadmaps is a tremendous source of information at the county level within the state and across the country about the conditions and outcomes of health. The National Opioid Misuse Community Assessment Tool is created by the National Opinion Research Center, or NORC, which is a fantastic rural health partner of ours. And this is a great county level data as well, and looking at different disparities too about opioid and substance use disorders. The CMS Medicare Health Disparities looks at chronic disease prevalence and is queryable to the county and state level. Hopefully you guys, as all FLEX programs, are familiar with what COMPASS is. It's the Critical Access Hospital Measurement and Performance Assessment System, created by the FLEX monitoring team, which is a queryable database that has clinical, financial, and community level data in there. The MDQIP data reports are a tremendous source of information as well. The Population Health Toolkit is created by the center and maintained, and there's 11 different data scenarios in there that crosswalk 4 different publicly available data sets to help you answer questions down to the county or hospital level about things that might be going on within your community. U.S. Census is amazing too. We're obviously going through a census time right now in our country with, completing that, which is done every 10 years. But the census actually just reformatted their web page as well to have lots of more visualizations of their data availability. And it's a gold mine of resources there. A couple more here, but the National Cancer Institute has a ton of information for you on the cancer prevalence within your state. And then the Kaiser Family Foundation and then America's Health Rankings through the United Health Foundation have on them a variety of different data sources that are covered in some other things like County Health Rankings. So County Health Rankings brings together a ton of different secondary data sources into one stop. And the Kaiser Family Foundation and the United Health Foundation web pages are similar in format, but they do have a couple other questions that they answer that some of the other places don't, which is why I listed them separately. So that's a ton of different sources. It's good just to tinker through them, find the ones that work for you, bookmark them so you know where to have access to them. And you can use them to help tell the stories of your unique communities or as your state as a whole about what's going on with various different conditions. We use these resources a ton within the organization to answer different questions and provide some of the services that we do. So with that, those are the things that I wanted to be sure to cover today to kind of lay the groundwork about population health, who's involved with it, what those incentives might look like, and where you can find some information that, at least publicly, without having to do a request. So I'm happy to answer any questions, or we can move into discussion as well.
Great, thank you guys. *2 will unmute your line if you have any questions based on what Tracy discussed. And thank you everyone who's logged in and utilizing their webcams. Kyle, Jill, Stephanie, who else I see? Natalie. So thanks guys. I think this is a nice little addition that we don't normally do when we're doing our webinars. Who has some questions for Tracy?
I do. This is Jill.
Is that Jill I hear?
Yeah, can you hear me?
I can.
This is the new normal for us doing these kind of meetings. Basically, what we did here in Arizona is we took we did an assessment of their community health needs assessments by hospitals, and it's not so much a question as it is a comment, but we took certain things out of their needs assessments, and we have a team that's working with each of the hospitals that we can work with on some of the population health initiatives. So I'm excited to be part of this collaborative because it's other people that are doing it around me, and I'm not as involved as I'd like to be. So this is giving me more ideas to be more involved in what they're doing.
Absolutely, and that's really the hope of it. And I think we have just like everything else we do, we have the standard bell curve of people who are doing all of the work and know what's going on, and their hospitals are already in ACOs and getting paid for performance, and then we have some that we're going to have to call these hospitals and ask them to get their community health needs assessment posted on their website and included into their strategic planning. So, yeah, that's great, Joe.
Well, I know for sure that, I think we're behind the curve on ACOs and getting paid for things like this in Arizona particularly.
Yeah, and I think the critical access hospitals are a little behind the general population of hospitals as well, but kind of such is the way it is. But I think it's a great, the benefit is the model's there, and if for whatever else is happening in the world, hospitals are starting to get paid for the health, well-being, and outcomes for health of their community, and that's a great thing, and it helps incentivize, and at least there is some financial incentive now, where 10 years ago, 12, 20 years ago, there was no incentive for that.
And how do we know, I guess, where do I look to see if our hospitals are actually getting paid for some of these incentives that they're doing?
Yeah, that's a good question, Jill. So I think the best place to actually find out if they're involved with different models and things like that is, so if there's a Medicaid program running within your state, it's through the state. But it's to actually reach out to them to find out if they're involved, because there's different types of models that they could be participating in, and you could track down their membership through kind of their mother organization, but it's probably best to actually communicate directly with them and find out what they're participating in. Unless, I think, Terry, you're on the line here, unless you know of some place where you could go to kind of query if they're participating in things, but I can't think of some place.
Yeah, there are some centers for that kind of an information. By far the largest of the rural hospital ACOs out there is Caravan, and if you go into the Caravan website, Jill, you can find all of the hospitals from Arizona that would be participating in that organization. But yeah, let's do another look here at TASC about any kind of a central kind of a clearinghouse of information of rural hospitals involved in ACOs. And again, one of the things that I know, for example, is that North Carolina is putting its Medicaid program into an ACO, and we're seeing more of that, I think, as you're saying, Tracy, on the Medicaid side of it.
Yeah, and I know, John, in Vermont, you're on the line or participating as well, and you guys have got a pretty interesting model there where kind of everyone is being herded into an ACO, for lack of a better, pay-for-performance model. It's a little different with, I know John's got, I think it's 8 critical access hospitals and maybe 12 rural hospitals throughout the state, so it's a little easier to keep your hands around a dozen or so hospitals than some of the states with larger numbers. I know Texas, you guys have got a bunch of hospitals in your state. Do you have, does anybody else have suggestions on ways to identify hospitals that are participating in value-based care models? Short of creating the value-based model, like I know Michigan, Crystal, you guys are helping run one of the ACOs.
Caleb?
Yes, sir.
This is Robert in Texas. I know one thing we've kind of talked about with looking at value-based purchasing is kind of looking at our hospitals who participate in CHIP, and kind of on their application they've been asked if they participate in value-based purchasing. I know that kind of can be challenging, but it kind of helps us lead somewhat in the right direction.
Yeah, that's a good suggestion. Yeah.
Yeah, that's a really good suggestion. I was going to mention that. This is Crystal. And the other point I would make is that beyond Medicaid, if you have relationships with your largest commercial payers, that's a good place to start as well. In Michigan, we have a Blue Cross Blue Shield incentive program that all of our critical access hospitals participate in.
Good. Suggestion. Again, *2 will unmute your line to participate in the discussion. What other questions do we have, guys?
I had a question. I liked how Tracy mentioned the MBQuip data, using some of that data to look at for population health. Do you have any specific examples, or could you speak to that maybe a little more, how to potentially look at some of the MBQuip data to help with population health efforts? Because I know here in Texas we're trying to get hospitals to submit more MBQuip data, so it would be kind of nice too if we could tie that a little bit with some of the MBQuip data.
Yeah, so there's 2 things that come off the top of my head. One is about EDTC, so the Emergency Department Transfer Communication. I think that has a lot, that just has so much to do with process and flow and partnership within an organization. So this may be I mean, you could look at patient outcomes and things like that for those that are brought in through emergency departments, through the ambulance services and things like that, and look at, you know, what happens with those individuals or something like that, and if there's improved patient outcomes or something over time based on something, based on a condition or something like that, if you wanted to. That's kind of going down a little bit of a rabbit hole, but that to me just speaks about care coordination from one of the basic services that we need our communities and our organizations to be providing, is to communicate clearly about who that patient is. Another thing that comes to my mind is about the influenza vaccine for healthcare providers. And that I think is kind of relevant to patient, well, it's relevant to patient safety, of course, but it's also relevant, I think, to how a population and community feels about prevention methods, and possibly could be about immunization in general and things like that. So I think, again, maybe a little bit of a rabbit hole there, but those are two measures that kind of come to my mind that could be markers for other types of, you know, communication or coordination, or also just kind of general health practices and preventative measures. Honestly, I haven't looked at one of those data reports in a while, so I can't remember some of the other metrics off the top of my head. Trying to think.
Well, Tracy, let me just add to that. If you do have hospitals participating in accountable care organizations, they have a whole nother set of quality measures. You know, Crystal would know those at heart. And in essence, 1/3 of those measures, at least it used to be, all prevention and wellness oriented. So those would be particularly important. You know, how are our patients getting wellness visits? Did we do a mental health screening? So those measures are designed to be population health oriented, and it might be really helpful to take a look at that as well. Talking about Caravan Health, I talked to their medical director, their chief medical officer, so we're talking about hundreds of rural hospitals participating in their accountable care organizations. And they've been able, because they have comprehensive data, to really single out what is the mental health consequence of having mental, you know, diabetes patients with a comorbidity of depression, for example, or what's the correlation between you know, some other type of disease from both a cost and a quality standpoint, and then, you know, kind of looking at another area that was identified by them as the whole long-term care and aging services costs. And they found that there was huge variation in both the quality of the care provided in long-term care settings and the cost of that care as well. They had data, also comprehensive data on emergency medical services. So that database, which has not been made public, but will, you know, somebody like Dr. Lowengeyer probably would respond if you have a particular question about some of this. And I find it really fascinating because it really hits a lot of the things that Tracy talked about. The real impact of not kind of working with your entire community, not reaching out to your public health agencies, etc. And in that value model database is really a lot of information that we can use to help improve the population of our rural communities.
Yeah, thanks, Crystal, for posting that resource. I was just flipping through it there quick, too, so that's great to see the different MB-QUIP metrics in there. And I think at Terry's point, like if you find that you do have hospitals in your state that are participating in the Caravan ACO, and you don't have a relationship with Caravan, you certainly can reach out to them, and and they may be able to provide you some roll-up information about what's happening and what are some of the findings that they're talking about there, specifically to Terry's point, within the hospitals in your state, and then you can design your program measures within whatever program it is to support some of those things, because there's only so many resources that Caravan can provide, and there's only so many staff that they have too, so they can't address all the issues that they're seeing within the models and the data that's coming into the ACO too. So how can you kind of work in partnership with them, with your federal funds, to support some of the initiatives that can help drive better care too and better outcomes?
Yeah, I think that's a good idea too. Most of the Caravan people are aware of the Flex program and Flex coordinators.
Well, and this is Jill again. I know that our Medicaid program had come to us to see what measures were in MB-QIP, and I did recommend some of the measures for them to use under the value-based purchasing. Where it went, I'm not really sure. It got quiet, so this is kind of reminding me that I should follow up and see what was done with the actual measures.
Sure.
And Jill, let me know, this is Terry again, let me know if I can help with anything in that regard. I'm happy to help any way I can.
Of course, thank you.
Awesome. What other questions do we have? How did the homework assignment go? So this is the first time that we're having homework. One, homework, and then B, pre-identified homework. That way, the hope in that is that you guys as participants can come to the collaborative with a bit more foundation and understanding, and have some questions. And the hope is that these will be examples that you guys can utilize when it comes time to identify action items following the collaborative. So how did you guys find that? Was it good, easy? You needed more difficult, more homework? You guys want a bunch of homework? Since I know some of you guys are doing homeschooling now with your kids. Do you want to show them your homework and work on it together? We can get more. So a good amount. So far it sounds good. Some of it was difficult to find. And when I was looking through it, it seemed like it was beneficial and relevant stuff, especially, mental health days and access to transportation. Those are both pretty relevant things, I felt, for hospitals to be considering, and then for you guys as flex coordinators to be thinking about.
I'm happy to show where to find some of it too. If you guys want, I can share my screen here and we can walk through where to find some of the information if that's beneficial. The ones that were challenging or whatever. Yeah. All right. I realize that box is kind of little, so okay. All right, so let's see here. That is not. Hang on a second here. Oh yeah. Sorry, hang on, bear with me here. So I'm giving TASC the first couple questions that were about like what is the population health and what are the facilities that are participating in value-based models within your state. So these are the data questions. So the first question, down here I juggle screens, was about question number 3 here, from 2014 to 2018, what was the opioid overdose mortality rate per 100,000? This is the U.S. rate. So I asked you to pick a rural county, and then what was the rate in your county. So this is from the NORC tool, so the National Opioid Misuse Community Assessment Tool. And this came out, I want to say maybe a year or so ago. Just a really, really cool tool. If you guys know the name, like Alana Knudsen and Michael Niet, that's where they work. So this is the tool here, and I'm just going to click on it. And they're just slowly loading here. But it'll show you the opioid death rates within the United States, and it visualizes it as a map. And you can select if you want to look at just states or counties. So the left here, you can pick the year range. You can choose if you want to look at all drugs or opioids. I think the question was about opioids specifically. And that got the right years and the county. So I'm going to try to zoom in here. Hopefully it zooms in for you. And I live here in Minnesota. There isn't some data available. So these are 2 very rural counties just up the shore of Lake Superior from us. This is the county where we live. We'll just look at this for St. Louis County, and you can click on it to view the details. So this is not a rural county because of the city of Duluth, but if you look at the rest of the county that goes all the way up to Canada, it's very, very rural, hundreds of miles of rural. But in any case, the opioid overdose death rate in this county for opioids in that age or in that time frame was 18.1 per 100,000 population. And then you can see over on the right side, there's a whole bunch of different demographic related information and socioeconomic information as well. So that's where to find the answer to that question. All right, I'm just trying to follow along in the chat here at the same time. Okay. The next question on the assignment was to look at what percent of adults 20 years or older in your county report frequent mental distress. or 4 days of mental health in the month, 14 or more days of mental health in the month. And so this data is actually from county health rankings and roadmaps. This is just such an awesome data source. So one of the counties up the shore from us, not where we live, but the next county kind of up the road is Cook County, Minnesota, which is rural and has a couple critical access hospitals in it. So if I go to Cook County here within the county health rankings and roadmap, I can scroll down to quality of life, and poor mental health days is actually the metric that we're looking at. So I'm just going to click on this. Hopefully this is displaying nicely for you guys, but poor mental health days is over here in the orange box. The description is here, the average number of mentally unhealthy days reported. And I can see that the overall rate in Minnesota on average is 3.1. It provides the range there. And Cook County is here at the tip of the state, and the average mentally unhealthy days for Cook County is 3.4, so slightly higher than the state. So that's where you find that question. The next one down the list was, among the critical access hospitals in your state, what percent offer outpatient mental health services? There's 26 or so % of CHs in the U.S. offered that service in 2017. So what in your state did? And this data is from Compass. So Compass is offered to the Flex monitoring team. If you go to their landing page over here under data, you can scroll down to the Compass data query tool. So there's a whole bunch of data in Compass that's actually publicly available now. It didn't used to be that way. It used to have to always have login information for it. But now there's a whole bunch that's publicly available. And then there is some login protected information if you want to see specific financial data for the specific hospitals in your state. So I'm just on the public side here, and if I go to community within Compass and scroll down, and we're going to look at county information. Again, I'll just choose the state of Minnesota. And we were, again, looking at Cook County. And if I scroll down to select specific measures, and I look measures for CH service next under behavioral health, and then view the data. And when I scroll down here, I can see that for Cook County and for the state, there's no specific county level data for this information, so actually that was just an exercise in nothingness for me to drill it down to county. But for the state of Minnesota, for outpatient mental health services and behavioral health, 32%, 32.7% of the CHs in the state provide outpatient mental health services, which is higher than the country. So that's where you find that one. And then the last data question was about, in your state, what % of the households do not have vehicle access? And when that percent in your state that don't have vehicle access increases, and when the proportion goes up of people that don't have access to vehicles, what happens to them reporting poor mental health days?